Marie-V is very smart, beautiful, red dress. She's a very famous expert in myeloma, and I propose to consider that she has won the debate, whatever. Now.
We can go to lunch now.
Yeah, that's a good idea. Now, I got lost somewhere in her talk, and I'm going to try to take you back to the right path. I got lost actually when she finished saying that we should not treat SMM, but we should recruit the high risk in clinical trials. Well, the principle of clinical trials is that you don't know the answer. If you know the answer before the clinical trials, don't run clinical trials. So Marie-V said that we should recruit patients in clinical trials to ask the question whether they should be treated, meaning today they should not be treated. So maybe we should just stop there and move on. Well, no, that would be not too easy. I mean, I've been putting some time on my talk, so I'll show my slides still. So my talk will be about, no, we should not treat SMM. But remember my word, we should not treat smoldering. Now, yes, I agree with Marie-V, and I agree with Professor Nagler. My talk is very difficult because all of you would love to be convinced that we should treat SMM, and because Marie-V is a very famous expert in myeloma. She has published in New England Journal of Medicine, which I've never done in my life and possibly will never do in my life. Maybe because IFM will never give me, I'm joking. That's for Philip. So she has published in New England Journal of Medicine that a treatment for high-risk smoldering is of great importance, and I have to say, I mean, she has shown some overall survival impact by treating versus no treatment. Although at the end of the day, you know how you analyze a Kaplan-Meier curve? You hold out your stats when you were in medical school. 1, 2, 3, 4, 5 deaths, maybe 6 here. Not very, it's not like, it's not like 100 versus 0. It's probably 5 versus 2. And at the end, the p-value is just at the limit. If we go one step forward, and I like actually this slide that Marie-V is not showing anymore, and I apologize, Marie-V, this is not an updated slide, but I like the slide very much because we always concentrate on this group, Lendex, the treated group. But I'd like you to take you back 1 second on the non-treated group, this group here. This group is supposedly a smoldering myeloma group. This group is a group that has not been treated in Marie-V's study. And if you look at the fate of these patients, which actually not good at all, the median PFS is what? Less than 2 years. It's actually 1.5 years. So I'm asking to you, if a patient, asymptomatic, no symptom, comes to you 3 months before starting symptoms, will you call that an asymptomatic myeloma or smoldering multiple myeloma? So I think we are mistaken. We are in a confusion here. We confound asymptomatic real myeloma, biology active, still asymptomatic, with smoldering. And my point is that Marie-V treats, and she's defending the fact that we should treat this patient, and I fully agree with her, but these patients are true myeloma that will become symptomatic within days, weeks, or months, and those are no smoldering at all. And actually, this has been very nicely depicted to us years ago by our master of us, all of this, which is Bob Kyle. Bob has very nicely showed that smoldering myeloma could be separated within 3 groups. One group here that is likely the group that Marie-V has treated. And you can see that this group here, within 60% of the patients will have developed a full-bloom myeloma within what? Couple of years, less than 5 years, probably 2 years, and 100% of them almost within 5 years. These patients are no smoldering at all. You think they are smoldering because they are asymptomatic, but they are no smoldering. They are real myeloma, biology active already, tumor cells growing in the marrow microenvironment working for the tumor cells already, that will become symptomatic and luckily came to visit you in consult some months before they become symptomatic. The smoldering are probably these patients here but definitely these two groups here and there. So I would agree that these patients, this group in the middle, is a smoldering high risk that might probably during their lifetime will develop myeloma. It is possible that these patients here, if they are diagnosed as 70 or 80 years old in their lifetime, will never develop myeloma truly. And probably we should think about this patient as a smoldering we really want to consider potentially treating if you think that this patient will develop full-bloom myeloma within their lifetime. So, what I'd like to share with you is two different cases. So case number one, 61 years old male, general practitioner performed an ESR routine lab test, not even knowing why, and the test was elevated. Then the patient got this when he come to see you, to visit you, prior story nothing, clinically nothing, CBC great, but maybe a mild anemia, and again we could discuss the value of this. Creat normal, calcium normal, LDH normal, beta-2 high, SPEP 45 gram per liter. For my colleagues from the US, 4.5 gram per deciliter, quite a high level of M spike, which is IgA isotype, serum free chain 300, which makes a ratio at 85, almost 100. So this patient does not have the criteria today to treat, the new criteria that Marie-V has discussed upon. This patient should not be treated. But do you think this patient, how long is it going to take for that patient to develop full-bloom myeloma, even asymptomatic, and after a couple of months becoming symptomatic? It's going to not take much. Normally this patient, within 2 years, is going to develop myeloma, truly, and you're going to probably treat this patient then, and you could consider potentially treating this patient today. But what about this patient? My same patient, 61 years old, same reason to come visit the hematologist. Now, everything is the same. CBC is perfectly normal. SPEP is 30, so it is a smoldering myeloma. IgG kappa, serum free light chain is perfectly normal. Bone marrow aspiration 12%. Everything is almost into a normal range. Would you treat this patient? That patient may develop myeloma in 15 years. Why would you treat that patient? That patient is 80 years old. That patient will never die from myeloma, though he might die from your treatment, because we've seen with Kiredex that it's not safe to treat the patient. There's still some side effects. On top of this, I just want you to know that treating myeloma smoldering, it's not something new. Marie-V has made a tremendous point, and she has treated the myeloma that are asymptomatic but not smoldering anymore, and show you should treat these patients. But treating smoldering has been done for years, and you never heard about all these treatments. Why? Because all of them are toxic, and none of them have made any difference for the patients. Marie-V has very nicely introduced that there are studies ongoing, and probably many of you has participated to Centaurus, and certainly, as I pointed out earlier in my last talk, will participate to Aquila, which is a study which objective is to treat smoldering, not the new myeloma definition criteria, ratio above 100, MRI 2 focal lesion, and more than 60% bone marrow involvement. Aquila will treat patients truly smoldering that potentially will develop myeloma during their lifetime, and ask the question, single agent anti-CD30 monoclonal antibody versus no treatment, which one is best? And potentially in your lifetime, because this is going to take 10 years potentially before we get the answer, in your lifetime you'll know if we should treat the high-risk myeloma. Now, you can go for, am I going to postpone the development of myeloma? Or you can ask the question that Marie-V has asked, can I cure myeloma by treating smoldering? The principle of, if you treat early on when the tumor mass is minimal, can you cure myeloma? And she has proposed a very heavy treatment, but as far as I know, she has not shown any cure, and so we still don't know whether this patient should be treated or not. And on top of this, is it you, Marie-V? Oh, that's you. So years ago, you have very nicely introduced what should be the criteria for smoldering myeloma that potentially will develop a full-bloom myeloma during their lifetime, and potentially although smoldering could be considered as to enter into clinical trial. And as long as I'm aware of, the conclusion of your own manuscript was low risk, no treat, high risk, no treat, but possibly if you have a clinical trial, you recruit, but if you have no clinical trial, no treat. And for early myeloma, you treat. So at the end of the day, what Marie-V has taught you is that you should treat myeloma, but I guess you knew this, and you should not treat smoldering, and I guess you already knew that. And so the final conclusions are, in smoldering, real smoldering, again, don't be mistaken by this asymptomatic wording. The real smoldering should not be treated. And Marie-V, I promise I will not bite you entirely.